I would like to thank the organizers and Dr. Neeta for having thought of me for this topic. I'll discuss quickly about different ways or rather novel ways of diagnosing diabetic retinopathy, because diagnosis is the main clinching part in diabetic retinopathy, basically because it is time bound. When we have the advantage of time in diagnosis, we will definitely have an edge in treatment. Why is this diabetic retinopathy suddenly gaining so much momentum amongst the masses and the doctors per se? Is because with the rise in numbers of diabetics, the rise in incidence and prevalence of diabetic retinopathy is increasing and worsening. The age at diagnosis of diabetes is coming to earlier decades, so is the age at diagnosis of diabetic retinopathy changes. So according to census, we are expected to have 80 million people with diabetes by 2030, but this is so alarming that we already have crossed 70. Amongst these people, 1/3 of them develop diabetic retinopathy changes at some point during their disease course. Out of these 33% further have severe diabetic retinopathy changes which warrant treatments, and out of which 20% require laser. Now, requirement of laser can be classified as the highest form of worsening, because it will either mean that, that the patient has vision-threatening macular changes or a proliferative disease. Diabetic retinopathy was just at number 17 20 years back in causing decreased vision. Today we are standing at number 6, and it is projected to come to number 3, only behind refractive errors or glasses and cataracts in the next 5 years. So basically, to sum it up, after 20 years of diabetes, all the patients with type 1 diabetes have retinopathy changes, and more than 60% of the patients of type 2 diabetes have some degree of retinal changes. These figures are Western. Our figures say 75% of patients with type 2 diabetes do have retinopathy changes as the duration of disease increases. Just to run through this quickly, this is a specific complication of both types of diabetes where all the vessels of the retina are involved. This can result in impairment of vision. In the early stages, this is a preventable cause of blindness, and that's why it is important. Once we cross the threshold, it becomes an irreversible blindness. We broadly classify it into 2 types. One is the non-proliferative diabetic retinopathy, which shows us some signs like hemorrhages, hard exudates, but nothing that we must get scared and run away of. The more severe disease is the proliferative diabetic retinopathy. Here we see new vessels that are formed on the retinal surface, which can cause recurrent bleeds inside the retina, over the retina, and in the vitreous cavity, thus resulting in loss of vision. And if left untreated or diagnosed later, then this can cause a tractional retinal detachment, which becomes almost impossible to restore the vision to the patient. Now, why is the retinal vasculature gaining so much importance? Because it is unique in that factor that it is the only vasculature in our body which are end arteries and which can be visualized in real time. We can see what changes are happening in the vessels as they are happening. So we can catch them early and treat them early. In most mild cases, the patient will not perceive any changes. This is where diagnosing and examining the patient is of the utmost importance. We can see small changes like hemorrhages and hard exudates and some subtle changes in the retina. The patient might just brush them off thinking it is our floaters. All of us have floaters at some point of time, that when we gaze across a plain wall or at the sky, we can see something floating. The patient will brush off these signs as a floater. Next comes the moderate disease where an attentive patient or someone who is habituated to reading or uses his eyesight for other small skillful work will appreciate changes. At this stage also, treatment will give a good result. In the advanced stages, where almost all the patients realize that now they have loss in vision, the treatment becomes very tricky and very unpredictable in its outcome. The previous classification of clinically significant diabetic edema is now only reserved for research purposes, because all papular edema is clinical significant. We cannot say that one part is not significant and the other part is significant. So now we follow a very simple classification of mild, moderate, severe. This is according to preferred practice patterns of the American Academy of Ophthalmology, where mild is there are changes which are not threatening or involving the macula. Moderate changes seem to creep or come near the macula, thus threatening vision, but the macula is still spared. And the severe diabetic macular edema is when the entire macula is involved, the patient's vision has dropped. I have showed these pictures because most of us practice teleophthalmology, where we take pictures, share them with our ophthalmologist friends, and then report them back to the patient. So when similar pictures are seen, once the central macula is involved, it becomes severe. When should a patient be called for examination? With type 1 diabetes, although all the studies say 3 to 5 years after diagnosis, all Indian numbers say that as soon as the patient is diagnosed with diabetes, be it type 1 or type 2, he has to be subjected to a fundus examination. And then depending on that classification or that grading, we can further decide when he needs to come back. If everything is well, we generally call the patient back after an year or so, and with increasing in severity, then we call them much earlier. In pregnancy, soon after conception and in the first trimester is a must for patients having pre-existing diabetes, and if there is worsening or progression of the disease, then we call them more often later. Now, what are the ways of diagnosing and storing this information? Basically, just like having basic sugar levels or basic other hematological investigations, it's good to have a fundus picture in the patient's records as a baseline. Now, this fundus picture will show us what the patient had at the outset. Fundus camera are readily available everywhere, and they record the fundus pictures. I'll speak about them as we go. The next test that most of us like to do in case we find an abnormality is a fundus fluorescein angiography. Here we study the microvasculature, the perfusion status of the retina, and competence of the vessels. We can see the black areas that are there, those are the capillary dropout signs. Now, like I said, the retinal vessels are the unique vessels in the body which can be seen real time. So there are various studies going on in this respect, that does this mirror other end arteries in the body like the renal vessels or the cardiac vessels, and once the results are out, I'm sure we'll see all these vessels in a different light. So basically, fundus fluorescein angiography is very routinely performed in patients with existing changes, just to note what is the perfusion status, which will tell us the prognosis of the patient. The next diagnostic tool that we very regularly use is the optical coherence tomography, or the OCT, simply because it is a non-invasive tool and it can be repeated. This is like studying the retina in an optical biomicroscope. We can see each and every layer of the retina. All the 10 layers can be separately seen, distinguished, studied, and minutest difference in these areas can be marked out. Like say, if there is macular edema, we can see swelling up of all the layers, distortion of its architecture, and even in proliferative stages where there are new vessels formed, we can see the drag or pull on the retina. So this is one tool which is very regularly used and which helps us decide what should be the course of management for the patient. Newer tools like 3D OCT and OCT angiography are coming up. Both of them are again non-invasive and repeatable. OCT angiography might perhaps replace the invasive angiography that is used, but again, this microcapillary status or microvascular status will definitely help us gauge what is going on in the rest of the body. There are various studies with OCT angiography being studied to know the renal status with respect to the OCTA changes. So once those results are out, I'm sure it's going to be a very interesting proposition. I've put this picture here because this is one of the commonest and most easiest tool that can be used even in a non-ophthalmic setup. This is a totally Indian product where it's a portable machine which can be put in a suitcase and carried along even for camp setups. We get good photos. The best part about such devices is that they use AI to gauge the grade of retinopathy. So the machine can gauge red lesions and white lesions. Red lesions are hemorrhages, white lesions are exudates or edema. So the machine can gauge and count the number of red and white lesions. We can store it. It can be dispensed to the patient immediately, the copy of the report. And this can be used in teleophthalmology because this machine can directly link you to your ophthalmologist who can decide further treatment. Now, various mobile-based devices are coming up. All standard companies like Bosch and Vogue have their own devices where you put a phone in the viewing camera and you can take good quality images, and storing, sharing is all easier. We have our very own Indian devices as well. Now this device in particular is the first Indian device which has been made. Basically this device only consists of a white handle wherein we put our own phone and our own viewing lens every time we want to take a photo. Only thing is that it has slightly steep learning curve, but once a person masters it, right from retinopathy of prematurity, all the retinal diseases can be imaged with this device, and this is a very simple and easy to carry device. So even in other non-ophthalmic, rural or even camp settings, this is a very useful device to have and carry about. Further, many other mobile-based devices are coming up. There are many do-it-yourself devices also, which we can collect all the material and then build our own device for ourselves. Basically, all this points towards teleophthalmology and artificial intelligence in screening and diagnosis of diabetic retinopathy, where such cameras, portable cameras, handheld cameras can be used to take photos. Even a technician can be trained to see what is red, what is white, where is it situated, whether it's there on the central dot or near the optic nerve that can be seen there. And that technician can right then and there classify the patient to have no disease or some disease, which is enough for us to work with. So once that is diagnosed, it can further be forwarded to the healthcare provider and to an ophthalmologist as and when treatment is required. So artificial intelligence is gaining momentum in this respect of diagnosing diabetic retinopathy at the earliest stages at the doorstep of the patient. This is important in our scenario because we have urban settings, semi-urban settings, and a huge chunk of rural settings where patients are not even aware that they have to get their eyes checked if they are suffering from diabetes. This is just to give an example. There are multiple projects going on similar lines in various places. We have a multicentric study for diabetic retinopathy where we involve our hospital at our place and our various branches which are there in other places. We have a fully equipped mobile, or this is a bus rather, which has all facilities for eye examination, including a fundus camera, where we go to the village. Some villages don't even have roads, but the villagers come to the place where we park the bus. We evaluate them, check them, and give them a report in the form of a printout or a CD whenever possible, and then ask them to come back after a stipulated period. So such projects are really going to help us take this cause of diagnosing and treating diabetic retinopathy forward, simply because it is a preventable retinal blindness in its early stages.